Welcome to the Myofascial Health Podcast, hosted by me, Unu. Follow along as I explore the depths of John Barnes' myofascial release approach on my road to mastery. Along the way, I'll be sharing the lessons I learn as I open my myofascial release practice in Austin, Texas, so that you don't have to make the same mistakes I do. Welcome back to the Myofascial Health Podcast. Now, I'm joined here by a very special guest. He's been a doctor for 30 years. He has a specialty in sport and exercise. He's a family physician. He's also a team physician for pro sports teams and even a surgical assistant. It's my honor to introduce, all the way from Sydney, Australia, Dr. Tom Cross. Thank you so much for joining me on this podcast.
You're very welcome, Unu, and thanks for having me. I appreciate it.
Now, I came across some of your research that you had done, and you are known to be one of the pioneers for what's called the cross-bracing protocol. And I have had a history of ACL tears and reconstructive surgeries, and I came across your research more recently, a few years ago, and then the worst thing happened to me. I tore my right ACL, and instead of doing surgery, which I had done before, I followed this cross-bracing protocol, and lo and behold, it went from a complete ACL tear to one that is intact, and so there's still some healing to do. But I wanted to reach out and kind of spread some awareness about this protocol that you've developed. So can you just, first of all, tell us what the cross-bracing protocol is?
Sure. So it's a different approach to ACL injury. It's a non-surgical approach. It involves bending the knee into flexion. And in the process of bending the knee into flexion, the idea is you're performing an approximation, or in medical terms, a reduction of the injured ACL tissues in the notch of the knee, or where the ACL is ruptured. So you're approximating the ruptured ACL tissues, you're holding them in position while they heal, and then you remodel the healing outcome in the weeks after the period of being immobilized in flexion. So that's, in an essence, it's a novel approach to ACL injury, a non-surgical approach. I have to say right up front that patient selection is critically important, that based on patient factors and MRI factors, you go back to the patient and you say, you're a good candidate for this non-surgical novel approach of bending the knee, namely termed the cross-bracing protocol, or CBP, or actually you're a poor candidate and you really shouldn't do it and you need a surgeon because you're profoundly injured, you're a young athlete that needs to return to pivoting sport. By the way, you've got a significant meniscal injury as well. So it's very important that all the listeners realize that patient selection is critical. I've been researching this novel approach for 11 years with a big team here in Australia, and we hypothesize that this approach is probably appropriate for 30% of ACLs overall, of all the ACLs. And the most appropriate are the young children and the older, lower demand adult. But some high demand young adults who suffer the injury are good candidates because of the nature of their MRI factors, that the ACL is ruptured, but we believe capable of high volume healing by adopting this treatment. So it's critically important that patients understand that it's not for everyone, and clinicians, namely the doctors, the physical therapists, the radiologists, the orthopedic surgeons, understand that this treatment, like most treatments in medicine, is highly dependent on critical patient selection. It's like anything in medicine. You don't offer a patient a treatment unless they're a good candidate for that treatment. And we can talk about what constitutes a good candidate and what's a poor candidate.
Yeah, what makes a good candidate versus a poor candidate?
Yeah, well, it's multifactorial, but you've got to look at, well, who is the patient that's injured, and what is the pathology of how badly injured is their ACL on the spectrum of ACL injury. And just on that point, as you mentioned in the intro, I've been a doctor 30 years. I was fortunate enough that my father was a orthopedic knee surgeon, and he was a magnificent father and equally incredible surgeon. Obviously, I'm biased, but he was arguably one of the best surgeons in Australia and led a lot of pioneering breakthroughs orthopedically and surgically in the 1980s and the 1990s, namely arthroscopic surgery, arthroscopic ACL reconstructive surgery, cementless total knee replacement, etc., patellofemoral reconstruction. And then it was his original idea in 2014 to bend the knee on a patient who really didn't want surgery and had a very jaundiced opinion on surgery because her two best friends had reconstructions that unfortunately were in the 15% that re-rupture. So she was sitting in the clinic, a 19-year-old high-level netballer, which is a sport similar to basketball, involves jumping, pivoting, sidestepping. And she was the one who triggered the research. And my father said, well, let's bend her knee, put a brace on. And we talked, my father and I, and said, well, let's do 4 weeks at 90, which will achieve hopefully the greatest reduction of the ACL tissue, allow it to heal, and then we'll gradually, incrementally bring the knee out straight in the weeks thereafter. She was patient number 1. She doesn't mind being talked about. Her name's Emma, and she did it. And then 1,025 people have done it since. So patient 1,025 adopted the treatment yesterday here in Australia, a 13-year-old girl, soccer player or footballer. And we've learnt a lot in those 11 years. So namely, I was taught that the ACL doesn't heal, that once it's ruptured, it's intra-articular. So it just falls away like a rope. So you're from Texas, aren't you?
Yes, sir.
So think of it like a rope. The rope's broken and it just falls away inside the knee. It's got no chance of reuniting. And we also got taught it's got a lousy blood supply,
Yeah.
which is not right. It's got a great blood supply. So, and the thinking was, and obviously this comes from the history of ACL. So prior to the late 1970s and 1980s, when these amazing surgeons around the world, and a lot of them were in the USA, pioneered ACL reconstructive surgery. So the athletes who suffered ACL injury usually became ACL deficient and they couldn't return to their sport. It was career ending. And these magnificent surgeons, thought up with this incredibly extraordinary pioneering idea of trying to restore the anatomy, recreate the nature of the ACL by doing tunneling through the tibia, the femur, and put a graft in there, a tendon, usually the hamstring or patella tendon. Obviously, there's many more grafts that have been chosen since, quad tendon, etc. And that graft does get a blood supply and comes to life, but undergoes biotransformation into a ligament. And that has enabled millions of athletes to return to this sport since. So the teaching was ACL doesn't heal. If you're a high demand young adult that needs to pivot, you need an ACL reconstruction. And I believe that for the first 21 years of my career. And if you're a low demand older adult, then you try non-surgical treatment first, which is physical therapy, and only cross over to surgery if you're unstable with everyday life. And that was the mantra. Children either had pediatric ACL surgery or they waited until they were skeletally mature and then underwent an adult ACL reconstruction. So this novel idea of actually the ACL can heal. We've seen ACLs healed in the last 50 years since the advent of MRI technology to visualize the ACL rupture and the healing outcome. We've always thought that these people that healed their ACLs were enigmas. They couldn't really explain it. What was interesting was they often had a combined MCL, ACL, so they were braced 30 to 90, and the ACL, because the knee was braced, because they had a combined MCL, ACL, had a closed reduction performed on it, and the ACL often healed alongside the medial ligament. Or those spontaneously healing ACLs were less injured ACLs in the spectrum in a patient who sat down all day with their job. So they were an academic, a student, an IT consultant, with the greatest respect, sat down all day with their knee inflection. They didn't get a Zimmer splint put on them to hold them in extension. They didn't see, say, someone like me 20 years ago, or a physical therapist who said, look, get your leg out straight. You've got to turn your VMO on and get your leg out straight. because we're worried you're going to get a knee contracture and flexion deformity, and we've got to get you ready for surgery. So what we've learned in the last 11 years is not all ACL ruptures are the same. So, and think of it like a fracture. If you fall and fracture your distal radius, depending on the speed you're running or the height you're landing from, your fractured radius is fractured in a spectrum from a bone bruise, which is like a partial tear of the ACL, to a hairline fracture, which is like a ruptured ACL with no separation of tissue, to, oh, it's broken and now it's slightly out of position. So there's gapping now of bone because you're running faster or you've fallen higher off the ladder. And then, well, it's a broken radius and it's displaced. And in the emergency department, we pick up the phone and call the anesthetist or anesthesiologist, the orthopedic surgeon, and the physical therapist, and we do a closed reduction on that patient. Pull on the bone, put it in position, put a plaster on it or a splint, and you've done a closed reduction of that fracture. And then we've got a fracture in the emergency department that's comminuted, displaced, intra-articular, because the athlete has fallen from a really high rung on the ladder, or fallen off the roof if they're a builder, or they're running fast, or they're skiing fast, snowboarding fast, or they've come off their scooter in any part of the world. They need a surgeon. We pick up the phone. Actually, this patient needs to go to theatre. They're comminuted, they're intra-articular. We need an open reduction, internal fixation of that fracture. So using the analogy of ACL, the ACL's injured in a spectrum according to how fast the athlete was running, how fast were they skiing, how high were they jumping. And that force is commensurate with how far the femur subluxes on the tibia, and in turn, how badly disrupted is the anatomy of the ACL. And also, what are the concomitant injuries that coexist with that profoundly injured ACL? So let's talk about an amazing athlete who plays for the USA, a female soccer player in your very good. Hopefully I'm not putting the mocker on these girls, but unfortunately, a lot of women who play soccer and men suffer ACL injury. Say she's running down the wing at maximal velocity and she's 21, she's powerful, she's highly trained, and she does an uncoordinated sidestep because she's distracted. There's something going on. There's multiple factors, as we know, for ACL injury. But she's generating a lot of power when her knee subluxes. So in accordance with the power she's generated, she unfortunately gets a large subluxation of the femur on the tibia, and that ACL or the femur rotates violently on the fixed tibia below it. That rotatory torque or force exceeds the tensile strength of the ACL, and it ruptures. And it not only ruptures, but it ruptures with a big gap, and it throws tissue out of position because it's so violent. Back to our Texan rope analogy, it's like the cowboy throwing the rope, and the rope gets thrown outside the knee. What exists with that ACL, and I call that the athlete's ACL, is a big bone bruise in the lateral compartment, often very anterior on the lateral femoral condyle. Often it's like a bomb's gone off on the MRI, and there's a subchondral fracture. There's lots of edema in the lateral femoral condyle. There's a posterolateral corner injury. And by the way, there's also meniscal injuries. There might be a ramp lesion on the medial meniscus. There's a vertical tear in the lateral meniscus, or worse, a radial tear on the lateral meniscus. So, and you see it on MRI, it's like a bomb's gone off. There's a large hemarthrosis because that ruptured ACL that's displaced in the moments after the injury, it hoses blood into the knee as that bleeding ACL, plus all the other things are bleeding, the bone bruise, the subchondral fracture, the capsular injury, the meniscal injury in the red zone, and you get a knee full of blood. So there are clinical indicators that the patient has landed to the right of the spectrum of injury of ACL. So I can often diagnose it over the phone without an MRI. So I say, well, can you tell me about the patient? And they say, it's a 21-year-old, they're an athlete, they were running fast. Their knee gave way with violence. They had a lot of pain. They couldn't weight bear. Their knee immediately swelled. All those things, markers of severity. And then you put the MRI up and They've got all those things we just talked about. Now, the opposite would be we had a beginner that was getting off the chairlift and also next to a beginner, and they got their skis caught and they fell over, and one of them felt a pop in the knee and it hurt. And then it got better really quickly, and they tried to put their skis back on, and their knee just doesn't feel right, feels a bit unstable. And then they tried to ski, and the knee gave way again. And then they got taken off the mountain. But by the way, it didn't really swell. They can walk on it. That's a less injured ACL. It's still ruptured, but they probably don't have a bone bruise. They've got no other significant concomitant injuries in the knee. The ACL is probably ruptured, but it's ruptured. We call this the skier's ACL, the beginner low velocity skier, very different to the skier for the Olympic team in, Park City, Utah in the US. So that ACL is less injured. It's ruptured, but it's still sitting in the synovial envelope. There's no displacement. The gap distance isn't that great. We believe that's a healable ACL by bending the knee. Whereas the Olympian going down the downhill at 100 kilometers an hour, when he or she falls, they get a profoundly injured ACL, proportionate with the force enacted on their knee. So this is a different way of looking at the ACL injury is, well, who is the patient? What sport do they want to go back to? What's their age? What are their comorbidities? Are they on medication that might affect the biology of healing of the ACL or the ACL reconstructive surgery? What's their social situation? Can they afford surgery? Do they have the finances? Are they a single mum or dad with young children? Is it their right knee and they can't drive? Have they had a bad experience with surgery on their other knee or another surgery, and they're really not that open to surgery and they believe the body can heal itself, etc.? So that's the patient. And then what is the pathology and how badly injured are they? And what are our chances of restoring anatomy with a non-surgical approach? And then you go back to the patient and you say, well, this is where you've landed on the spectrum of ACL injury, and this is what we think or hypothesize is how you're going to heal if you do rehab alone, or you brace 30 to 90, or you do this thing called cross bracing. And this is how we think that will serve you moving forward. And these are the activities you want to go back to. What do you think? I usually, majority of the time, I let the patient decide, the patient, their parents, their partner, and knowing that they can always cross over to surgery if it doesn't work or they're not happy. Obviously, with the caveat that you don't let them go back to high demand, high energy sport without, very thorough follow up and looking after them to make sure if they have a poor outcome, that they don't go back to that activity and trash their knee and cause a whole lot of damage. You stop them from doing that.
Yeah.
And you say, well, you haven't got a very good outcome. You need a surgeon if you want to go back to soccer. Thanks very much. Or if they've said, well, I'm hanging up my soccer boots, I'm just doing Pilates, yoga, walking, spin class, they might be fine with their relatively poor healing outcome or no healing. And they've adapted to being ACL deficient and they're quite happy. So it's very much, let's educate the patient about what do they need for their activity level and their sport that they want to go back to, and what is the pathology and how can we restore the anatomy either non-surgically, or actually we can't restore their anatomy, we need a surgeon to restore their anatomy with ACL reconstructive surgery or ACL repair surgery, which is, and I'm sure you're aware that certain ACLs are amenable to the proximal injured ACL right up the top. And then you've also got that bear implant in the USA where the doctors are trying to save the ACL and, avoid the complications of taking a graft and tunneling through the knee, etc. So that's a whole other conversation. But that's also, I commend these pioneering surgeons who are pioneering that space of ACL repair and saving the ACL, etc.
You got it. So, just to catch up my listeners on what we're talking about is we're talking about the ACL, or the anterior cruciate ligament, and it's one of the ligaments inside of your knee, and it often gets torn in sports that require pivoting, cutting, jumping, and those kinds of dynamic activities. if someone were to tear their ACL and all they wanted to do was get back to jogging, they could jog straight forward and backward, probably without any complications or problems. But when we talk about sports, especially those where it's team sports or there's contact sports, you're gonna have to pivot and make split-second decisions. And if there's a high velocity and you're not ready for that, that's where this knee buckling in comes into play. And I had torn my ACL in my left knee the summer after my high school, and I had gotten surgery for it, and it kept re-tearing. And this is where I'm a little bit biased, and this is why I love the cross bracing protocol because it challenges this paradigm. What I love that you shared was that your dad, even though he was a knee surgeon, he met Emma, who was not wanting to get surgery. And for me, I usually think of surgeons like, if all you got is a hammer, then everything looks like a nail. And so if you're a surgeon, you're going to do surgery. Whereas he had the human heart in him and said, okay, well, I have this patient here who doesn't want to get surgery. How can I best serve her? And that thus then was born this protocol. And something that tends to happen when you get ACL surgery and you heal from it, one of the first things you try to restore is your knee extension, meaning you straightening your knee as much as possible. And I remember going through surgery and saying, hey, hearing my physical therapist say, hey, we have to stop this extensor knee lag. And if you don't get that extension in the beginning, then you're going to have a tough time. You can get a contracture. And I just went based off of what they said. And what you are saying is actually what we need to do is put the knee in a closed reduction position. And that's bending the knee at 90 degrees. And that actually helps approximate or reduce the ends of the injured ACL and it helps them connect again. And that challenges the normal paradigm. And I know that when I was growing up, it's exactly what you said. Everything that I had heard and read was the ACL doesn't heal on its own. It doesn't have a good enough blood supply. So that the only thing that you can do, especially if you want to get back to sports, is get this surgery. And I love that you said that. You said the ACL has a great blood supply, which goes against what people have been teaching or saying for decades. And I love that you and your dad had humility to say, hey, this is new stuff that we're coming across. We're not just doing things because it's tradition. I think one of the worst things you can hear, especially when you're looking for healthcare, is, oh, why do you do it this way? And if the only thing that you hear is, well, this is just the way we've always done it, then I would say you might want to look for a different path. And then, yes, everything is dependent on the patient. This isn't a one size fits all, but it's very appropriate for one, kids. I firmly believe that kids shouldn't have to have these surgeries. They're still growing. And if you do anything to mess up that growth plate, that creates further complications down the line. And then obviously, if you're not trying to get back to a pro level or collegiate level or Olympic level sport, this is a good avenue to consider. And so the athlete ACL tear that you described is what I just went through recently. I was playing co-ed soccer with my wife, and we were on the same team, but I was running down the wing or the sideline, challenging for a ball. I kicked the ball, and then when my right leg planted, I think the person who I got the ball away from kicked where they thought the ball would be. It happened to be my leg, and I was running at full speed, and so my knee blew out, and I couldn't put any weight on it. It felt very unstable. And then I came across your research, and this is where it all depends on the patient. And I love that you're the type of doctor or physician that says, really honestly, all I do is I educate the patient to the best of my ability and I let them make that decision. I don't know that that always gets honored here in America. And even if you have the experience or the years of whatever, it doesn't necessarily mean that you are looking for that patient's best interest. And why I say that is the first surgeries that I got, the first three surgeries I got in my left knee, it was from a minor league baseball pitcher's team's knee surgeon. So I thought he had the experience, but it kept re-tearing. And so when I changed everything, I could see that there were differences. And so the surgery that ultimately I had success with was one deemed the anatomical surgery method. And that's when they take a wider approach to putting your ACL in. And that helps with this internal rotation component of the knee injury. So, something that you've listed in your research is hey, an ACL tears because the shin bone will go forward, and then there's a rotational component that goes inward. And in every physical therapy textbook that I read or even online, if you say, what's the function of the ACL? Most of the times it will just say it stops anterior translation of your tibia or it stops your shin from moving forward. And so if a surgeon, especially one who isn't up to date with the knee function, and they only account for the shin moving forward, then when this internal rotation component comes into play with sports that is pivoting and cutting, then you're going to not have that function. And so even though it might feel taut when you're doing a special test like a Lockman's where you're trying to test that, you're going to miss that because it will feel taut and functionally correct in that position. But when you're playing sports where the demands are different, you're not going to test for that functional component. Now,
Do you mind if I just jump in,
yeah,
Yunus?
please.
So what you're talking about is completely correct, that the ACL controls anterior posterior translation, which is the tibia moving forward on the femur above. But its main role is posterolateral stability of the knee, which is where you plant your foot and change direction. That's called the wind up
Hmm.
or cutting. And then you need to, when you plant your foot, you've got a fixed tibia and your femur rotates on that plateau of the tibia, sort of like, the Grand Canyon where there's these plateaus or mountains. You're a mountain rock climber, aren't you?
Yes, sir.
Think of it like you're climbing up the tibia and then there's the plateau on top,
Hmm.
and then the femur sits on that and rotates on that plateau. And the main role of the ACL is to prevent that posterolateral rotation of the femur on the tibia. And you're also a Texan, so you understand ropes. So it's like a rope inside your knee that engages and stabilizes the knee from that rotation, sort of like a check rein. And it comes into play when you're pivoting, cutting, landing. Perhaps, and I wasn't present at your surgeries, but if you examine a patient and they've got a good Lockman, so it's a nice crisp endpoint, you must do a pivot shift test on the knee, which tests the second component of the ACL, the posterolateral rotatory stability. And that's highly dependent on the correct tunnel positioning that the surgeon achieves. Basically, have they recreated nature? Now, surgeons have been talking about this for 45 years since ACL surgery began in the late 70s. And there was a very pioneering surgeon in America called Freddie Fu, who a lot of your listeners, particularly the older ones my age and beyond, will remember Freddie Fu. And he tried to restore anatomy by doing two tunnels in the femoral area because the femoral footprint is so complex and large on the where the ACL attaches. And he was trying to recreate nature so that you could, what you're saying, not only recreate the stability in the anterior posterior direction, but also the rotatory component of the ACL. So, with the greatest respect, if the surgeon puts the femoral tunnel too anterior, then you won't control the rotatory aspect when the athlete goes back to sport. So, the high volume expert surgeons get the tunnels right. They get they they really put the tunnels in the right spot, and they give the patient an excellent graft with high volume tissue. So they take a good graft. I'm biased, but I like the patella tendon because it's got bone in the tunnels, which has got a greater pull-out strength than I believe the soft tissue equivalent, like the hamstring or the quad tendon, which has got tendon at one end, bone at the other. I like the patella tendon for an athlete because I think it's got a higher braking force or strength. So we could talk all day about ACL surgery and ACL graft selection. But at the end of the day, we should send our patients to very, very good surgeons who do a lot of ACL surgery. They love it. They do 200 a year. They get very good at it. They get good results. The patients, they talk with the patient and communicate and get good results. So what you talked about earlier, it is very hard to have a long consultation with a patient about ACL. I take 60 minutes, sometimes 90 minutes with a patient to talk to them about what are all your options. So what have you done? How badly injured is your anatomy? And here are all your options. You could do rehab alone, you could brace 30 to 90, or you could do cross bracing, which going to 90 for a variable period of time, 2 weeks, 3 weeks, or 4 weeks, and then start bringing your knee out straight. Or we've got this amazing knee ACL surgeon and you need him or her because you're so badly hurt. And by the way, you've got a bucket handle meniscal tear. You're not a candidate for non-surgical treatment. You need a surgeon. So that takes time and energy, and not every doctor's got that amount of time. Certainly the surgeons don't, because they spend half their week in theatre, so that they're operating. And so they've got 50% less time than me. I can consult all week. So in the defense of the surgeon, they really need to be working with a physician or a family doctor or a physical therapist who spends the time educating the patient about these are all your options. What would you like to do? Now, sometimes we have to make the decision for the patient when they've got a bucket handle meniscal tear, when they've got a severely injured ACL and they're young and they want to go back to soccer, field hockey, American football, ski for USA. And we're doing them a disservice by doing the cross bracing protocol and delivering a low volume heal, because we can't restore that anatomy because it's so badly hurt. If you think about it, it's simple, but at the same time complex, in that you need to spend time with the patient, spend time considering the injury, how badly injured is the anatomy, and can you restore it non-surgically, or do you need a surgeon? But the patients love having this, what's called a shared decision-making consultation, where they're very much a part of it, and someone's doing that. With the greatest respect, there's a lot of nuances to it, and ideally the clinician or the doctor should do it, because the physical therapist doesn't have the knowledge of all these things, like what's the risk of the patient getting a DVT because they've got some weird hypercoagulable disease, factor V Leiden deficiency, etc., etc. What medication are they on? Are they on the oral contraceptive pill and they're at high risk of a DVT? Are they on a biological treatment for their psoriatic arthropathy, and that biological treatment will affect the healing of their ACL? It'll also affect the biological healing outcome of their graft. So all these things matter, of who the patient is, what are their medical comorbidities, what medication are they on, what's their social situation, where do they live, are they a single mum or dad with young kids, what type of work do they do, will they get paid if they do this bracing protocol, or is it unpaid, etc., etc. So certainly the physical therapist can be involved and have, but there's certain elements, the medical side of things, where the doctor really needs to give their opinion and make sure that the treatment's not only safe, but effective. So it's safety and efficacy, we say in medicine.
I
So,
completely agree. And on that note, what other attributes would you say you would look for when trying to find the right physician to work with? So something you said is like a shared decision with you and the patient. But I think sometimes, especially when you're in a lot of pain, you're looking for a solution. Or if you're really wanting to get back to sports, you're just looking for a solution. And that kind of impulsiveness can take over. And if you're there, I think sometimes it's not uncommon for me to hear a surgeon just say, you just need surgery. So, what other recommendations would you have to looking for the right physician to work with?
okay, well, once again, I love surgeons and we need them, and they save our lives if we're in a car accident or if we have a significant fracture. What we're talking about is elective surgery for an ACL,
Yes.
which is not an emergency. It can wait. It's an emergency for a professional athlete because the clock's ticking and he or she wants to get back as soon as possible. But for most of us, it's elective surgery. So we do have time to stop and think, unless we have a locked knee, with a bucket handle meniscal tear that needs a surgeon. So if you take the approach that most of the time it's not an emergency, we have time to stop, think, and think about what treatment we would like to adopt. The clock is ticking for if you wanted to do the cross bracing protocol, however, and we like to get the knee into flexion in the first 7 to 10 days when the ACL tissues are fresh and open to healing. Just like any wound, a fracture, a laceration of the skin, a tendon injury, you want to achieve the reduction with fresh tissues. Now, we talked about it before, Unu, that if you think about the ACL like a fracture or a ruptured Achilles or a mallet finger, we all know as doctors and physical therapists and surgeons, there's a window of opportunity to achieve an effective reduction and heal those injuries. No one's ever thought about the ACL that way. So it's incumbent on us to say, well, there's an ACL sitting in the clinic or the emergency department. The clock's ticking. We need to have a shared decision-making long consultation with that patient. We need an excellent MRI with high resolution imaging. We need a double oblique sequence to get a better look at that ACL to see the pattern of injury. And then we can go back to the patient and tell them about how badly injured their ACL is. Where is it on the spectrum from normal anatomy to minimally injured, like a partial tear, to moderately injured, it's ruptured, but it's intrasynovial, or it's profoundly injured and destroyed. And it's large gap, displaced, partial femoral footprint avulsion, etc. So to do the treatment where the patient's got their whole suite of non-surgical and surgical options available, you've got to get the job done in 10 days from time of injury to the patient making their decision of what pathway they want to go down, or we tell them they need a surgeon because they've got bucket handle meniscal tear or profoundly injured and they're high demand young athlete. So in that 10 days, the team of four, so I call it the team of four. The team is a physician that loves athletes and wants to enable athletes to return to sport. So they really care. They understand knee injuries, they understand ACL, they understand the whole gamut of non-surgical and surgical options. That's the clinician. Then you need a radiologist and a radiographer and a fabulous MRI to get a very accurate assessment of the knee injury, the ACL injury, and all the other injuries that coexist. Then you've got your diagnosis, you've understood the patient, and you've got the diagnosis of the anatomy or the injury. And then you go back to the patient, have this very long consultation, which takes me 60 to 90 minutes, especially if they're choosing a non-surgical treatment. If it's black and white, you need a surgeon, it's a quicker consultation. And then in that team of four, you either deliver the patient to the surgeon and get a reconstruction with an excellent ACL surgeon who's part of your team, or you deliver the patient to the physical therapist and they're going to do rehab alone, or they're going to brace 30 to 90 for 6 weeks, or they're going to do cross bracing method. And then at 12 weeks, you do another MRI and examine their knee for their healing outcome. So laxity testing and how good does that healing outcome look? And is that acceptable for that patient? And if it is, we carry on. And if it isn't, we can cross them over to our surgeon in the team of four. So we're all working together for the patient. The surgeon in your team of four, he or she does not have the time to do a 1 hour consultation for an ACL. They just don't. As we said, they're in theatre 50% of the week, like doing fabulous operations. They don't have time to sit down for an hour. Some surgeons might want to get involved in the decision-making and enjoy the classification of the ACL and whether that one's healable or not, or maybe that one's repairable based on their skill set. I think I can repair this ACL and I don't need to take a graft. These are really interesting times in ACL management where hopefully all those four professionals, clinician, physical therapist, radiologist, and surgeon, are all on the same page. They're all collegiate, collaborative, care about the patient, and we're all trying to deliver a stable knee, functionally rehabilitate the patient, and return them to the activity and sport that they love, etc. So that's the idea.
I love the team approach, and I completely agree. And I think what it kind of boils down to is with these kind of elective surgeries, like an ACL, obviously, if you fall out of a building or you get in a car accident, by all means, get the surgery. You need that. And again, We need surgeons. This isn't about anything against surgeons. But when we talk about ACL tears and hey, this isn't a life and death thing, you have time. And so you have time to see what options you have. Now, obviously, if you do the cross bracing protocol, there is a window of opportunity, this 10-day mark that, again, it's your knee's going to swell up. You want to brace that if you choose that option. And I think what I'm hearing is you want to pick a doctor or a surgeon who kind of walks you through that process. Obviously, surgeons don't have that much time, but you need to work with somebody who says, hey, these are your options, this is what you could do, and this is depending on what you want to get back into. And I think that is the perfect way to state it because, I would be wary if you go to the surgeon and they immediately recommend surgery for an elective surgery like an ACL tear. And so that's where I think I hear you saying, hey, it's a team approach. You have a window, but it's not anything you have to make a split second decision because it's a life or death thing. And I would agree with that. And the doctor that I trust the most here in Austin would say the same thing. He walked me through it. His name is Dr. Michael Burris. He did train under Dr. Fu, so it's interesting that you were able to kind of reference Dr. Fu in the knee surgery world. And so I love that. Can I ask you, you know, what are the advantages and disadvantages of the cross bracing protocol?
Sure. So the advantage is that, well, it's non-surgical. So unfortunately, surgeries have very minor, rare complications, such as you have to have a general anesthetic. Most people are fine with that because they're healthy, young. You can get an infection from surgery. So we're talking about cross bracing is a non-surgical approach. Surgery can get a DVT, can get a stiff knee. They've got to take a graft so that you can get donor site morbidity that the hamstring or wherever they take the graft from, patella tendon, quad tendon. The advantage is that no one's touched your knee if you do the cross bracing method. So there's no surgery. So you haven't got any tunnels in your tibia or femur, et cetera, et cetera. So that's a very alluring advantage for a patient. And we just use you, Unu, as an example. You've had 4 surgeries, a primary and 3 revisions on one of your knees. And then you came across the cross bracing method when you researched recently and chose that for your contralateral ACL injury. That is quite alluring for a patient, and often if the patient's a child, the parent. Let's try this non-surgical treatment first that has none of the unfortunate risks of surgery as our first position, knowing that we can always cross over to surgery. If we get a poor outcome on examination, which is called laxity testing, or on MRI where we've got low volume healing. Another advantage is there's no pain. It's inconvenient and challenging, but the patient doesn't have any pain. And they've got their knee inflection, and some of them get anterior knee pain if they've got some pre-existing patellofemoral chondromalacia. We can manage that with physical therapy methods of releasing, posterior chain, front of the knee, retinacular tissues, etc. So that'd be the main advantage, that it's non-surgical. If you want me to talk about the disadvantages, if biology doesn't come to the party and you don't get high volume healing and you don't restore the anatomy of the knee, you've wasted time. You've lost time. So you've gone through something inconvenient, challenging, and for not a lot of gain. And then you have to say, well, now I need to go to the surgeon in your team of 4 and have a reconstruction. Now, if you've spent a lot of time in the beginning of the journey talking to the patient, their partner, the parents, patients don't mind if it doesn't work because they've consented and they really want to try this treatment first. And they always know that it may not work. And this is based on level 4 evidence-based medicine, expert opinion. I actually give them a percentage chance of it working based on where they are on the spectrum of injury when we classify the ACL on the acute MRI. So they're actually ready for it if they don't land in a good healing outcome. They say, well, I'll never die wondering, in 15 years, geez, I should have tried that non-surgical approach first. I just jumped straight into surgery. I gave it a go. It didn't work for me. And then I had a reconstruction. Or they say, I gave it a go. And then they say, well, actually, I'm going to adapt and I'm going to do the best functional rehabilitation on the planet. I'm going to work with my physical therapist, and I'm going to probably just retire from soccer, basketball. These are the older patients, remember, not the 20. We're not talking about 20-year-olds
Yeah.
where that's not an option. And you can't say that to a 20-year-old, like just retire from American football or basketball. You want to enable them to get back to their sport. Yeah, I've done a patient education booklet that goes through all the advantages and disadvantages, and I
Yeah.
can share that with you, and you can share it with your listeners because it's quite a long list. I've written down every advantage that we perceive and every disadvantage so that the patient's fully informed before they adopt this treatment, which is how you have to practice medicine, whether it's orthopedics and sports medicine, oncology, you name it, neurology, gastroenterology. It's all about having a shared decision-making consultation with the patient, telling them this is your diagnosis and these are all your non-surgical treatments and these are your surgical treatments. What would you like to do? That's the way medicine should be practiced.
100%. And I couldn't agree with you more. I just am saddened that I don't think that that is how it's practiced here in America, at least for every patient. And I wish it was.
It takes time, and a lot of doctors don't have a lot of time. And
Yeah.
in their defense, their vast knowledge of experience of patient care and medicine, they're trying to do the right thing by steering the patient into the best treatment they think is for that patient. It just takes a little bit of extra time and energy to lay out the argument of let the patient decide because it'll be crystal clear to the patient that that is the right option. The doctor's running late or, et cetera, et cetera. There's lots of reasons why the physician or the surgeon tries to make the right decision for that patient. But yeah, what we're talking about takes a lot of time, energy and time, which a lot of doctors don't have.
Yeah. And I would just like to reiterate that what you're saying with the cross bracing protocol is not to overtake surgery. But I think what you're saying is, hey, maybe surgery shouldn't be the first option. And we've been able to show that ACLs can heal. But if it doesn't give the function that you're looking for sports, then you might cross over and try to do the surgery then. Is that fair to say?
Yeah, that's a really interesting point. What I would say is that there's different populations of ACL on the planet and that there are different patient groups. And so we call that sport specificity in sports medicine. So for an example, if you went to the base of the mountain at Lake Tahoe, Salt Lake City, Aspen, and you had 1,000 ACL sitting in the clinic, I would say the vast majority of the low velocity ACLs or the beginners who rupture their ACL are healable ACLs. And I know that's a controversial thing to say, but their anatomy hasn't been that badly hurt. They're ruptured, but they've got a minimal gap distance. There's usually no displacement outside of the synovial envelope, and you bend the knee and you can restore their anatomy. So I would argue 80% of those ACLs sitting in the clinic in Salt Lake City in the low velocity skier, the beginner, are healable. Very different to the high velocity skier, the elite skier going 100 kilometers down the mountain or jumping 5 meters in the air. They're severely injured because of the force that went through their knee. So let's just talk about that population. And there's a lot of those in America, in Europe, in Japan, Australia, New Zealand. So we call that the skier's ACL. Okay, now we go to the best athletes in the USA playing American football, soccer, basketball, baseball, you name it. They're running at high velocity, they're pivoting, they're jumping high, they've got quads of steel, they're powerful. 80% of them are profoundly injured when they rupture their ACL. So they're not good candidates for the cross bracing protocol. This is our experience of 11 years. I've looked after 3 to 4,000 ACLs. 3,000 I've sent to surgery and 1,000 have adopted the cross bracing protocol. So that's a very different population. A 15 to 35-year-old powerful athlete running at speed, jumping high, usually needs a surgeon if they want to return to these high demand sports that need a solid ACL construct. Very rarely do we put the MRI up and see a healable ACL with minimal gap distance, no displacement, not a lot of detensioning of the ACL construct. And we can look that 22-year-old in the eye and say, look, I think we can restore your anatomy if you just bend the knee and bring the ACL elements together. So that's that population. And then you've got the population of children, the 8-year-olds to 14-year-olds that rupture their ACL. If they're prepubescent, so they haven't reached puberty and they're not as fast and not as strong, they usually have a healable ACL. It's not every case, but we feel that they're often a good candidate for the across bracing because they're young and they're not that injured. Contrary to that belief that all children pull their tibial tubercle out, so they get a bony avulsion, most children get an adult ACL. They get a injury to the ACL somewhere between the tibial attachment and the femoral attachment. It's quite rare to see the pediatric ACL where it's pulled out of the tibial attachment with a bit of bone, which just needs a surgeon to plug back in. The next population is the low demand, athlete that's sort of over 38, has a couple of young kids and does their ACL playing basketball socially or skiing. They're not as strong as they were when they were 25, so they can't generate the same power. They might have a less injured ACL without the displacement. They're lower demand. They're quite happy if they get a healed ACL, but it's a little bit lower volume or it's a little bit elongated, and that will serve them fine moving forward. So they're another big population in the ACL world. So basically what I'm saying is not all ACLs are the same. Not all populations of humanity who suffer ACL are the same. We're not all elite athletes, 15 to 35. There's a lot of other people rupture their ACL. What intrigues me the most is what's happening in the developing world, in the countries that don't have MRI, don't have surgery. How can we help them? They could all empirically brace to get a better healing outcome. People in Africa, Asia, South America, they've got no MRI, they've got no surgeon, but they rupture their ACL playing soccer, or they rupture their ACL on their scooter going to work or going to school, and they put their foot down, do their ACL. This treatment has the ability to help a lot of people who've got no access to surgery whatsoever. But there will be physical therapists in those countries. They have physios and they have doctors and nurses who can help them. And we could go back to that principle of trying to categorize where they are on a spectrum of injury based on clinical grounds. How fast were you running? How hard were you jumping? How fast were you going on the scooter? How much did it hurt? Did your knee swell? Could your weight bear? And if the answers are, I actually could walk on it, didn't swell that much, feels a bit loose, I wasn't going that fast on the scooter, I was slowing down, they've got a healable ACL probably. Let's bend the knee and try to heal their ACL for the rest of their life. Or if they're going 60k an hour on the scooter, they put their foot down, very painful, can't weight bear, very swollen. They've probably got a more profoundly injured ACL, and hopefully they don't have a bucket handle meniscal tear blocking their knee. Obviously you've got to be that's got to be on your radar that there's other serious injuries in their knee. So yeah, these are all intriguing aspects to this piece of research.
I love that. And I think you're adding to this body of work, one that I am very passionate about. And to give some context to where I'm at, it's because when I tore my right ACL more recently, it was what you would have categorized as an athlete's ACL tear. And I know when you saw my first MRI, you're like, I'll be honest, I'm just going to be frank, not a whole lot of joy after seeing this. But after following the cross bracing protocol, I also do physical therapy and myofascial release. My most recent MRI, which I discussed with my trusted knee surgeon, he actually just said, hey, you have an ACL there. Now, the challenge will be when you return to sports. And he asked me, are you trying to get back into soccer? And I'm ready to hang up the cleats, And so I'm in this older category where I just want to be able to rock climb again and be able to play pickleball, some low impact activities. And then he said, you know what? Like, I think your ACL could hold up. You don't need to see me unless once you return to those activities that you find that there's instability, and then we might have that discussion, But he's very much working with me every step of the way. And I just want to reiterate that, if you're ever being pressured to do an elective surgery, you might consider somebody else. And I just love that you have created this body of work that even sometimes you're like, this is controversial to say. And it's not. Like when I read your research, 90% of the patients showed some level of ACL regrowth. And I'm like, that's worth it to me to take a risk if it's 90%. If it was like 50-50, maybe not. But like 90%, that was like, it's at least worth it. Now, that being said, I didn't have a meniscus injury. I didn't have these other factors involved. So for me, it was worth it to take that risk. And lo and behold, I'm here having a conversation with you and saying it was 100% worth it. And I can't thank you enough for coming up with this with your dad and putting it out there, and someone like myself halfway across the world is able to benefit from your body of work. So just thank you for that.
You're most welcome, and it's lovely to meet you and also know that you did this without me supervising it, that you initiated the treatment, you researched it, and I'm finding people around the world who have adopted the treatment without me being involved. And indeed, there's a doctor in San Diego, Dr. Shiraj Ashur, who is become a close friend and colleague of mine. He's adopted the treatment for several patients in San Diego without me being involved. And he just thought, I like this. This is a good idea, particularly for my pediatric patients. And of his own volition, has started adopting and treating patients with the CBP. So that's an example of a very pioneering doctor in the USA. And there's other doctors in the USA, Dr. Jonathan Dresner in Seattle, Dr. Justin Conway on the East Coast, who are pioneering this treatment and wanting to research it and help patients. Dr. Hod Dunbar, he's an orthopedic surgeon in Santa Barbara, California, who's open to this CBP. Dr. Hod Dunbar did his fellowship with my father 15 years ago, and he came to Australia with his wife, Winnie, and two kids, and learnt from my father. And he's a close friend and colleague of mine. One thing we need to make sure the listeners understand is you mentioned the 90% healing. Well, in that 90% of the first 80 people who did the CBP, we were bracing all comers. We didn't have our classification system that is predictive of ACL healing, we believe. So that still has to be published. We're desperately trying to publish our MRI classification system, which can inform the clinicians and the patients of where they've landed on the spectrum of injury, and accordingly, what spectrum of healing you'll achieve if you do rehab alone or bend the knee and do the CBP. In that 90% that healed, there were some that got very good restoration of their anatomy and some that healed, but it was quite thin and quite elongated. So there's a spectrum of healing, and you can't call it a healed ACL. Like it's healed, but it's not very good healing if it's very thin and very elongated. So that has to be appreciated, that we defined healing as continuity had been restored from femoral attachment to tibial attachment. But in that spectrum of 90%, which was called continuous or contiguous ACL healing, there was a spectrum of healing, of high volume healing, parallel or tight healing, and low volume elongated healing. They're quite different. And you wouldn't want to send a 22-year-old back into competition with a low volume elongated. I would feel nervous
Yeah.
that she or he will re-break and re-rupture. And then you've got another problem on your hands. You've got a high energy second giving way that could have injured their meniscus, their articular cartilage, etc. So that, we looked at your MRI and you've got high volume, slightly elongated. So I think that will serve you fine for the rest of your life. That's my prediction. You've hung your soccer boots up. You're going to go to the gym. You're going to train hard. You're going to run. You're going to play with your kids, coach. I think it'll be fine. It'll perform well for you. So just everyone needs to understand that just as there's a spectrum of injury, there's a spectrum of healing, and the patient factors and MRI factors are critical to this whole paradigm of thinking. And setting the patient's expectations at the right level is critical, just like everything in medicine.
100%. You stated that so beautifully. Now, if someone is looking to work with you, how might someone get in contact with you?
Well, you can just email my reception team at the Stadium Clinic in Sydney. Just trust me, I'm working hard. I've never worked harder in my life, but my capacity to classify MRIs and be involved in the care of patients in Australia, New Zealand, and internationally, it's right at the limit. But I will do my best to help to read the MRI and see whether that patient's an excellent candidate, a good candidate, an average candidate, or a poor candidate. So I classify them according to gap distance, displacement. Is the ACL dying and involuting because it's 5 weeks old, and there's no way we can wake that ACL up to heal because it's dead, for want of a better word. So, and all the other serious injuries in the knee that need a surgeon, etc. We talked about that. I'm really trying to educate doctors, radiologists, knee surgeons, physical therapists. So that's the team of four. And then I'm hopeful that in the months and years ahead, there'll be a team of four in Austin, Texas. There'll be a team of four in San Antonio, Texas. Team of four up in Kansas City. And I don't need to be involved. And the doctors and the team of four understand the concept of the spectrum of ACL injury, the spectrum of ACL healing, who are appropriate candidates for the CBP based on patient factors, MRI factors, and you don't need Tom Cross involved. So we're hoping to get more science. We need more scientific publications. So there's probably undeniably people listening who think this guy from Sydney is stark raving mad. And, you've got one scientific publication, it's low level evidence. There's lots of scientific limitations. And I don't blame them for saying, look, you need to generate more science. And we're desperately trying to do that to get much higher level science, randomized controlled trial, an RCT starting in Australia this year. There's an RCT in New Zealand starting, and an RCT probably starting in the UK. The doctors I mentioned in the USA are trying to research the CBP in the USA in the months and years ahead. So like everything in medicine, you've got to prove it with a scientific method, but that takes time. And in the meantime, we're not doing a lot of harm. So we're watching the metrics of safety and efficacy extremely carefully so that we're not hurting anyone, and we're not hurting anyone. Of the 1,000 patients, 7 had a very stiff knee, 5 got a below knee DVT, no one's had an above knee DVT, no one's had a pulmonary embolus, no one's died. If those things were happening, I'd shut down the research and shut it down. If there was safety concerns or efficacy concerns, I wouldn't be talking to you today. We would have given up years ago. But there's enough compelling results and very happy patients out there that inspiring myself, the research team here in Australia, the doctors I mentioned in the USA, the doctors and physical therapists in Europe that are championing the idea. There's a clinic in Barcelona, Dr. Ramon Cugat, who has become an extremely close friend and colleague who's championing the CBP in Europe. He loves it. He came to Australia in February and spent 3 days with me with his wife, who's also a doctor. She's a pathologist, and their head physical therapist, Alfred. And they had time with me and time with Jane Rooney, who's a physical therapist leading the education on CBP. And they went and spent time with her in Melbourne. So there's fires burning around the globe trying to investigate the CBP for our patients. And gradually we'll get more science. With science, you either prove or you disprove what you're investigating. Obviously, I'm hopeful that we can prove it, but if we disprove it, then people will always know that this treatment doesn't work. The critics say that healed ACL is scar tissue and is weak. Now, our re-rupture rate is 15% in 700 people that are 1 year to 11-year follow-up. So we're watching that metric very carefully. How many of them re-rupture? We want to investigate the biology of the healed ACL. What is it that leads to a very high volume, very strong healing outcome? And what is it that might inhibit the healing? Is it there's something they're doing with their physical therapist? What's happening with their nutrition? Do they have high protein, Do they collagen supplement? Do they smoke? Do they vape? What medication are they on? What's their genetics? Do they meditate? Do they use any type of adjunct? All these things matter in terms of the ultimate healing outcome and tensile strength and survivorship of that ACL. So these are pieces of the research that the people, hopefully other researchers in the USA, in Europe, take the lead and help collaborate with me and my team here in Australia and New Zealand. So it's an exciting space. I go back to what we've talked about all along. Anything in medicine has to be effective and has to be safe. And we're just giving patients another option. That's all we're doing. And I'd have to say the patients love it. And we've got 100 people that have done the cross-bracing method, and then we now have 101 Unu Tran. So they've done cross-bracing and then they've done reconstructive surgery in their other knee. We've got multiple patients that have had primary and then revision surgery on one knee and then done cross-bracing on the other. And we're going to include them in a scientific publication and do a qualitative and a quantitative analysis of both their journeys of, well, what was that experience like and what was this experience like, and do laxity testing on their knees, do patient-reported outcome measures, return to sport, survivorship, and ultimately osteoarthritis. So how is their knee in 20 years' time? And what's the ACL reconstructed knee feel like? And what's the cross-bracing knee feel like? So all these things will come in time. That's another intriguing part of the research. And another thing we didn't talk about, but we've adopted the treatment for ruptured grafts. So 11 people have done the cross-bracing method for a ruptured ACL reconstruction, and it works.
Wow.
So all the same things matter: gap distance, displacement, time to brace, other injuries in the knee. So I was very reluctant to do it, and a surgeon rang me 2 years ago in Sydney, Anthony Leon, and said, Tom, I've got a 20-year-old female high-level athlete. She's ruptured her graft, but I think she's a good candidate for the cross-bracing method. And so that's a surgeon reaching out, and we co-managed her with the CBP. She healed, and then she chose to not go back to her pivoting sport, and now she's an elite rower. She said, look, I just don't want to go through a surgery again, and I don't want to go through the CBP again. I'm actually going to go over here and become an elite rower because I'm sick of doctors and physical therapists, with the greatest respect, and I don't blame her. But she got a very good heal on laxity testing, on follow-up MRI. She had a visible disruption of her graft. So there's a lot of people around the planet who re-injure their graft. If it's 15% of millions, if they've got the right pattern of injury, which is gap distance, displacement, they can do the CBP rather than have a revision. So that's another manuscript we're working on. So
I love that. I think what I am hearing is you're challenging this paradigm and you're not replacing it. You're just saying, hey, we can add to it. This is another option that we're going to help the patients with. And I just want to say thank you again, Dr. Cross, just because you've taken time out of your weekend. I know it's Saturday there in Sydney. And I just want to thank you again for not only you sharing your body of work. I'm one of the ones who benefited from it. And once I told my knee surgeon about it, he's actually recommended other people to try the cross-bracing protocol. So just know that it's slowly growing here in Austin, Texas. But I just wanted to thank you for being open and honest, being able to be a pioneer in your field and being able to share this research from your dad and yourself. And I couldn't have asked for anything more than to have this conversation with you. Thank you so much.
Well, you're most welcome. And, we talked about it earlier off the podcast. I just spent time in Kansas City a matter of weeks ago with the American Society of Sports Medicine. And I absolutely love the Americans' positivity, their openness to new ideas. It's a breath of fresh air. And, I love the USA. I spent a year of my life there as a child in Columbus, Georgia. My father was doing a fellowship with Jack Houston at the Houston Clinic. Every time I visit the USA, I love the American attitude, and it's a pleasure to meet you, and it's a pleasure to meet the colleagues I met at that conference in Kansas City. And I look forward to working with you and your colleagues moving forward. Thanks for your time. I appreciate it.
You're very welcome. Thank you for yours. Enjoy the rest of your weekend.
You too. See you, mate.
Take care. Thanks for listening to another episode of Myofascial Health. I help myofascial release therapists create beautiful websites for their MFR practices, even if they aren't tech savvy. If you're just starting your MFR practice, or you're an experienced MFR practice owner, learn more about how I can help at www.myofascial.health/website.